Hello, my name is Carlos Pestana. I'm going to help you prepare for the surgical questions on USMLE Step 2. I'm going to do that primarily by reading vignettes and then discussing them with you. Now, the vignettes that I'm going to use are not as extensive as the vignettes on the actual exam. The vignettes on the actual exam have a lot of additional information, and mine will zero in on the key findings, okay? Now, every now and then, it'll be convenient for our review to cut away from my face and go to either a summary of the essential points or a decision tree. How should we approach a particular question? But most of the review will be me reading the vignettes and discussing them with you. And you can follow those with your own textbook. I might add the textbook also has a narrative part, which is not part of the review and is not part of what I use on the live courses either. So we're going to begin with a chapter on trauma. We're going to begin with the first part that we do in the management of a trauma patient, which is the famous ABC, airway, breathing, and circulation. So the first vignette says, the patient involved in a car accident is fully conscious and his voice is normal. Now you realize obviously there will not be a question on the exam that says only that and then asks you what are you going to do now. But what I'm giving you are the key words that tell you in a question, this patient does not need an airway. So if the only information pertaining to airway says the patient is fully conscious, his voice is normal, he doesn't need an airway. However, there may be more. Let me read the next vignette. A patient with multiple stab wounds arrives in the emergency room, fully conscious, and he has a normal voice, but he also has an expanding hematoma in the neck. Well, now this patient, as we speak, still has an airway. But very soon he will no longer have an airway because that expanding hematoma in the neck is going to interfere with it. So this patient needs an airway. Now, he needs it now. He doesn't need it 10 minutes from now when we'll be in deep trouble. So now he needs an airway. Because he is awake, he's going to need some form of an anesthetic for that to be done, either general or topical. And because there are no contraindications in the vignette, the airway should be placed the usual way by the normal anatomical passageways, either via the mouth with a laryngoscope or via the nose. Now the next vignette, vignette number 3, says a patient with multiple stab wounds arrives in the ER fully conscious, and he has a normal voice, but he also has subcutaneous air. That is to say, emphysema, in the tissues in the neck and upper chest. This is another example of a patient that right now doesn't seem to need an airway, but in fact needs one. Because this particular sign, a trauma patient with air in the tissues up here, indicates an injury to the trachea or a major bronchus. And that airway, therefore, has to be placed in a very specific way. If you blindly put a tube down the throat, it's going to go not necessarily into the distal segment of the transected trachea, and it might end up insufflating the tissues in the mediastinum instead of the lungs. And so this is an airway that has to be placed under direct vision. Essentially, the technique involves the use of a fiber optic bronchoscope, which is threaded through the endotracheal tube. It is then, the fiber optic bronchoscope is advanced until the physician can see the injury in the trachea or major bronchus, advance it beyond the injury, and then the tube, that is the endotracheal tube, is advanced over the bronchoscope and the bronchoscope is removed. We're going to repeat all these, by the way. Let me continue with the next, and we're going to have a summary. All right, we move now to vignette number 4. A patient involved in a severe car accident has multiple injuries and is unconscious. He's breathing spontaneously, but his breathing sounds gurgled and noisy. And when you read that question on the exam, you obviously know right away that the air is having trouble getting in and out of the patient because it's making a noise that indicates that. And that, of course, is an indication for putting an airway. But there is an even more important indication that perhaps is less obvious. That is the fact that this trauma patient is unconscious, is in coma. A trauma patient who is in coma cannot be trusted to maintain an airway. We have to provide it. I should emphasize that I'm not implying that any individual who is unconscious has to have an airway. We're talking specifically about a trauma patient. Now, in the technique for placing this airway, obviously you don't need an anesthetic. The patient is already unconscious. However, the vignette doesn't preclude the use of the normal anatomical passageways, and so it will be somewhat similar to the one we discussed earlier. You can put this endotracheal tube via the mouth or via the nose under direct vision with a laryngoscope, and you do not need an anesthetic. Now, as we move on to the next vignette, things are going to begin to get a little more complicated. We're now on vignette number 5. An unconscious patient is brought in by the paramedics with spontaneous but noisy and labored breathing. You know already this patient is going to need an airway. This is a trauma patient who is unconscious and his breathing is noisy. But there is more. They relate that at the accident site, the patient was conscious, but was complaining of neck pain and was unable to move his lower extremities. He lost consciousness during the ambulance ride, and efforts to secure an nasotracheal airway were unsuccessful. So now you realize you got two problems. The patient has a cervical spine injury. The patient also needs an airway. And your first question might be, which one do I do first? Well, that's easy. Airway always takes precedence. Airway is always the first thing we have to look after. However, knowing that the patient has a cervical spine injury then narrows down the options you have for the technique you're going to use to place the airway, because you cannot use any technique that hyperextends the neck, that moves around the neck of the patient, because that would compound the existing injury. A very neat way to put this airway would be to use a fiber optic bronchoscope, thread it through the endotracheal tube, pass it down so that under direct vision one can see where the tube has to go, and that view of where the tube has to go is not gained by hyperextending the neck and lifting the tongue with a laryngoscope. But any other technique that might appear on the answers in which you realize that doesn't hyperextend the neck, that doesn't move the head, it would be an acceptable way to place this airway. And we still have one more that represents a different situation, vignette number 6. A patient involved in a severe automobile crash is fully awake and alert, but he has extensive facial fractures and is bleeding briskly into his airway, and his voice is masked by gurgling sounds. Well, this is a patient who also needs an airway. He's literally drowning in his own blood. But now the normal anatomical passageways are not available to you. The nose is smashed, the mouth is smashed, the whole place is full of blood. And this is a classical indication to go through the neck. The easiest, most available way to do this would be to do a cricothyroidotomy. But a percutaneous tracheostomy would also be an acceptable answer. Percutaneous. Keep in mind that a standard open surgical tracheostomy can only be done in an operating room with all the exposure and help, and it's not something that can be done in an emergency setting under less than ideal circumstances. Let me now pause for a second and repeat the indications for an airway. We're going to cut away from my face and just look at pictures now that give you the key points that we have made. All right, so the indications for intubation in the trauma patient include an expanding hematoma in the neck. In that case, you can intubate via the mouth or the nose, and if the patient is awake, you have to use a quick general anesthetic or a topical one. Another indication is if air is present within the tissues of the lower neck and upper chest. In that case, a fiber optic bronchoscopy for diagnosis of a lesion and the intubation are the technique to be used. The fiber optic bronchoscopy gives you the diagnosis of the lesion of the trachea or major bronchus, and we intubate over the bronchoscope. Another indication would be the patient is in coma. In that case, you can intubate via the mouth or nose, but obviously no anesthetic is needed. Another indication for intubation in a trauma patient would be if the patient has extensive facial fractures and is probably drowning in his own blood. In that case, a cricothyroidotomy or a percutaneous tracheostomy would be the best answer. Remember that an open surgical tracheostomy should only be done in the operating room. You can see in this picture here a CT scan that demonstrates extensive facial trauma with fractures. So if you had a picture like this in a patient who requires an intubation, you realize that this one should be done with a cricothyroidotomy or a percutaneous tracheostomy. Let's also remember that if the only relevant information given is that a trauma patient is awake and alert and speaking in a normal tone of voice, then the airway is okay. He doesn't need an intubation. We should also remember that airway management precedes the treatment of any other lesion, but if that other lesion is a cervical spine injury, then the intubation must be done in a way that does not move or hyperextend the neck. All right, we've covered the A of the ABC. Let's move to the B. The B stands for breathing. An unconscious trauma patient has been rapidly intubated in the ER. He has spontaneous breathing and bilateral breath sounds, and his oxygen saturation by pulse oximetry is above 95. In that vignette, I gave you the 3 findings that say to you, this patient is breathing okay. I do not need to intervene to do the breathing for the patient. What are those 3 findings? Well, he has spontaneous breathing. He generates his own breathing motions. The air is reaching both lungs, as evidenced by the fact that there are bilateral breath sounds, and the pulse oximetry has a good number. Okay, so we now move to the C of the ABC. The C stands for circulation, and essentially that means, is the patient in shock or is he perfusing normally? Let me read vignette number 8. A 22-year-old gang member arrives in the ER with multiple gunshot wounds to the abdomen. He's diaphoretic, pale, cold, shivering, anxious, and asking for a blanket and a drink of water. His blood pressure is 60/40. His pulse rate is 150, barely perceptible. Now, you recognize right away 2 things when you read that vignette. First thing you recognize immediately, this is a patient in shock. He's pale, he's cold, he's shivering, he's anxious, he's asking for a blanket and a drink of water, he's covered with perspiration. Blood pressure is very low, his pulse rate is very fast, barely perceptible. You know that is a patient in shock. But the second thing you read on that vignette is this is a trauma patient. This is not any other kind of patient. So let's first ask ourselves, why would a trauma patient be in shock? There are 3 possibilities. Number 1, and by far the most common, the patient is bleeding. It's hemorrhagic shock, hypovolemic shock. But there are 2 other possibilities. The trauma patient who's in shock could have pericardial tamponade or tension pneumothorax. Now, for either of those 2 to be the problem, the patient must have been injured, among other places, in the chest. So that for a patient who's in shock after trauma, For that to be due to pericardial tamponade or tension pneumothorax, the vignette clearly will have to say that he was shot in the chest or stabbed in the chest, or that he had blunt trauma, because in blunt trauma, of course, the chest is automatically one of the potential places that is injured. If indeed the problem is pericardial tamponade or tension pneumothorax, so there will be some physical findings. There will be distended neck veins or forehead veins, there will be a high CVP, and in the case of a tension pneumothorax, also there will be difficulty breathing. There will be a side of the chest that has no breath sounds, that is tympanitic to percussion, the trach is deviated. So you realize there are a lot of questions that come to our mind after we read a vignette of a trauma patient who happens to be in shock. So let's review together a little decision tree. Let's cut away from my face now and go to words on the screen. And this is a decision tree that I'm suggesting you follow when you read in a vignette that a trauma patient is in shock. The first question that I want you to ask yourself and go read the vignette again to find the answer is the chest involved? Well, if the vignette indicates that the chest is not involved, that's the end of your differential diagnosis, because the diagnosis then has to be the patient is bleeding. But on the other hand, if the chest is involved, you now need to ask ourselves another question. Are the neck veins distended or is the CVP high? Because if the answer is no, then regardless of the fact that the chest was involved, the diagnosis remains bleeding. Because had it been pericardial tamponade or tension pneumothorax, the neck veins would have been distended, the CVP would have been high. But on the other hand, if you have a trauma patient in shock on whom the chest is involved and the neck veins are big and distended or the CVP is high, now you realize that the diagnosis is either going to be pericardial tamponade or tension pneumothorax. So now to answer which of those two, ask yourself another question. Is it difficult to breathe? When you look then at the vignette again, if you realize that it is indeed difficult to breathe for the patient, then the diagnosis is tension pneumothorax. But if there is no indication at all that breathing is a problem, then the diagnosis is pericardial tamponade. Here is a picture of a tension pneumothorax. I need to emphasize to you that normally you would not ask for a chest X-ray on a patient that has a tension pneumothorax. But if the vignette came with a picture, you would recognize in this picture that I'm showing you that the right side of the patient's thorax, on your left as you look, it's all full of air and the mediastinum is pushed to the other side. So this is the way a tension pneumothorax would look on an X-ray. Let me emphasize again, you don't want to ask for an X-ray on the vignette that we read. So now that we have reviewed that decision tree, let's read again the vignette number 8 that led us to that. A 22-year-old gang member arrives in the ER with multiple gunshot wounds to the abdomen, and then there is the description of a patient in shock. The vignette doesn't say that the chest is involved, therefore the diagnosis is hemorrhagic hypovolemic shock. Well, now we've got a lot of talking to do, though, as to what are we going to do next. Because we realize that shock is a true emergency. Shock is a condition that will kill the patient if he's not promptly and effectively treated. So for many years, we have always taught in medical school that a patient who's in shock needs immediate treatment. But interestingly enough, for many, many years, when we talked about that immediate treatment that was needed, our emphasis was on replenishing the blood volume. Infusion of fluids intravenously, starting with Ringer's lactate, following with blood or blood products. And almost as an afterthought, we used to say, and by the way, we also have to stop the bleeding. We have now reversed that sequence. We now realize that if the circumstances are right, we should first stop the bleeding, and once we've done that, then we should replenish the blood volume. Now, what are the circumstances that we have to have in order to be able to proceed first to stop the bleeding? Well, there are two. One, we must already know where the bleeding is happening in the patient. In other words, we don't have to do a lot of diagnostic studies. We know already where the site of bleeding is. And number two, we are in a place where we can do something about it, like we're in a hospital where we can do an operation and stop the bleeding. Well, let's read again this vignette. This is an individual who's described as being in the emergency room and he was shot in the abdomen. So we know that he's bleeding into the abdomen. He already is in the emergency room, which means there is an operating room right around the corner. And so the correct answer on this patient is do an emergency exploratory laparotomy, stop the bleeding, and then fill his vascular tree. First with Ringer's lactate, then with blood products. I'm going to repeat this topic actually in a number of the vignettes that follow. So let's keep reading vignettes, and we're going to emphasize when should we address stop the bleeding first, when we cannot do that. We're now in vignette number 9. During a bank robbery, an innocent bystander is shot repeatedly in the abdomen. When the emergency medical technicians arrive, they find him to be in shock. A fully staffed trauma center is 2 miles away from the site of the shooting. The question then would be, what should the EMTs do? And 10 or 15 years ago, EMTs were told that in a setting like the one described here, they should start intravenous lines on the patient. They should begin infusion of Ringer's lactate. In other words, they should begin to resuscitate the patient before they moved the patient. We now realize that, as this vignette describes, with a fully staffed trauma center that is only 2 miles away, it makes more sense for the emergency medical technicians to just put that patient in the ambulance and run as fast as they can to that fully staffed trauma center so that a prompt exploratory laparotomy can be done, the bleeding can be stopped, and then the blood volume can be replaced. Let's go to vignette number 10. A 19-year-old male is shot in the right groin during a drug deal gone bad. He staggers to the hospital on his own and arrives in the ER with a blood pressure of 90/70 and a pulse rate of 105. He's squirting bright red blood from the groin wound. Well, here's another example where you can and you should stop the bleeding first. You can even see the blood coming out. And in fact, this brings another issue. What is the best way to stop bleeding that you can see in the patient where it's coming from? And it is direct pressure. The correct answer in this patient is you put a sterile glove and you put your finger right over that bleeding vessel and you stop the bleeding with direct pressure. Then you will have time to give the fluids and the blood replacement and eventually move the patient to an operating room where the injury can be properly repaired, but you can immediately stop the bleeding with direct pressure. The correct answer, incidentally, would not be a tourniquet, would not be putting clamps blindly in the middle of all that blood without seeing the actual place. All right, we move to vignette number 11. A car accident victim has arrived in the ER, and the initial survey indicates that he is unconscious with spontaneous but noisy bleeding and a blood pressure of 80/60 with a pulse rate of 95. His head and neck veins are not obviously distended. Let me stop for a second and review. As we have read so far, we know this patient is going to need to be intubated. He is a trauma patient who is unconscious with noisy breathing. And we also know that he's in shock, and we know that the shock is from bleeding, because the vignette already told you that the neck veins and the head veins are not obviously distended. So you know those things are needed. Now, as you keep reading, you realize that the question itself already took care of the intubation, because the next sentence reads, while the anesthesia team is intubating him, another team is placing a central line for venous pressure measurement, others are examining his chest and abdomen. So now you're at the point where he's already being intubated. That's not the answer you need. But you know that this is a trauma patient in shock. And you know the shock is from bleeding. And you might then figure out, from what we were talking about a minute ago, well, our order of business now is to stop the bleeding. But wait a minute, where is he bleeding from? Where is he bleeding into? You don't know. He's a trauma patient who's bleeding. But you don't know if he's bleeding into the chest, in the mediastinum, in a pleural space, if he's bleeding in the abdomen, if he's bleeding on a pelvic fracture, on a femur fracture. And so this is a patient who doesn't fit the criteria that enables you to proceed with let's stop the bleeding first, because you don't know where it's coming from. You're going to have to do studies to figure out. This is going to take a little time. So in this case, you start by infusing fluids. You start the fluid resuscitation while you do the studies that will eventually tell you where is the bleeding coming from. What this patient needs then is ideally 2 16-gauge intravenous lines, one on each arm, through which you infuse Ringer's lactate at a realistic rate, a liter or 2 in the first 20 minutes, to be followed then by the blood products as soon as they are available, and hopefully by that time you would have done your CT scans and your physical exam that eventually will tell you where the bleeding is and whether it needs to be stopped surgically or whether perhaps it has stopped on its own already. But the correct answer in this patient is gain access to major veins and pour fluids into him. Let me add that if the vignette were to say that you attempted to put intravenous lines in the arms and you were not successful, then you can either do a cut down at the ankle or a direct puncture of the femoral vein in order to be able to give the fluids. Let's move to vignette number 12, which is the same theme again, except this is a child now. A 40-year-old child has been shot in the arm in a drive-by shooting. The site of bleeding has been controlled by local pressure, but he is hypotensive and tachycardic. 2 attempts at starting peripheral IVs have been unsuccessful. Now, you realize that in this vignette, the bleeding has already been controlled. Local pressure has already taken care of the bleeding, and eventually a proper repair will be done. All we need now is provide the fluids. The challenge you're being given is that the attempts at starting peripheral IVs have been unsuccessful. In this case, had it been an adult, you would have said the answer I need is either a cut down at the ankle or a direct pressure, or direct puncture of the femoral vein. But in the case of a child, the avenue of last resort to gain access to put fluid in the patient is intraosseous cannulation of the proximal tibia. Move now to vignette number 13. During a wilderness trek, a 22-year-old man is attacked by a bear and beaten repeatedly in the arms and legs. His trek companion manages to kill the bear and to stop the bleeding by applying direct pressure. When paramedics arrive 1 hour later, they find the patient to be in a state of shock. Transportation to the nearest hospital will take at least 2 hours. Now, you might remember that a few vignettes ago, we talked about a scene where somebody had been shot in the lobby of a bank, and this was only a couple of blocks away from the trauma center. And we said in that case, the paramedics should not waste time trying to start intravenous lines, because they could very quickly take the patient to the place where the proper intervention could be done to stop the bleeding. But here we have a different setting. Here the bleeding has already been stopped by direct pressure. And we are 2 hours away from a place where further treatment can be done. You don't want this patient to remain in shock for 2 hours. And so indeed the answer here for what the paramedics need to do is to start a couple of intravenous lines and start infusing the Ringer's lactate as they move the patient to that facility that is 2 hours away. All right, we're going to move now to vignette number 14. A 22-year-old gang member arrives in the ER with multiple gunshot wounds to the chest and abdomen. Now, you should already be alert. You already realize the significance of a trauma patient where both the chest and abdomen are involved, because you know that should this patient be in shock, you got a little longer differential diagnosis. Let's keep reading. He's diaphoretic, pale, cold, shivering, anxious, asking for a blanket and a drink of water. His blood pressure is 60/40, his pulse rate is 150, barely perceptible. Again, we have a trauma patient in shock, and you already know that the chest is involved. However, there is a very significant omission on this vignette. It doesn't say that his veins are big and distended or that his CVP is high. Typically, an exam question has to give you all the findings that would enable you to make a diagnosis. So this could not be a question of a patient who happens to be with a pericardial tamponade or tension pneumothorax. The vignette would have had to say he had big distended veins or he had a high CVP. So if you were asked for the diagnosis, it would be shock. However, you might actually be asked something better with this vignette. And that question would be, what other information do you need? And then you realize the obvious answer is you need to know what his CVP is, or you need to know if his veins are visibly distended or not. Let's move to vignette number 15. A 22-year-old gang member arrives in the ER with multiple gunshot wounds to the chest and abdomen. You again are alert now, chest and abdomen. He's diaphoretic, pale, cold, shivering, anxious, asking for a blanket and a drink of water. His blood pressure is 65/40, his pulse rate is 150, barely perceptible. So we have so far a trauma patient who's in shock on whom the chest is involved. Now you knew the next question you were going to ask yourself in our little decision tree we reviewed. As we keep reading, there is the answer. He has big distended veins in his neck and forehead. And this is immediately telling you the diagnosis is either pericardial tamponade or tension pneumothorax. And you don't even have to ask ourselves the next question on the decision tree because the answer comes on the last line. He is breathing okay, has bilateral breath sounds and no tracheal deviation. So it should be obvious to you that the diagnosis here is pericardial tamponade. And in fact, it's a diagnosis that is already obvious with the clinical findings. If you had a question on the exam that is doubtful, you think it might be pericardial tamponade, but you're not really sure, the way to answer that is to do a sonogram, a quick scanning of the precordial area with a sonogram, and that will tell you whether there is fluid in the pericardial space or not. But here you don't even need that. You already have plenty obvious clinical evidence that this patient is pericardial tamponade. The correct answer you're looking for is one that first opens the pericardial sac and therefore evacuates the blood there. That could be a pericardiocentesis, a pericardial tube, a pericardial window, in some circumstances even a medium sternotomy. And while that pericardium is being evacuated, it would help the patient to also receive either intravenous fluids or blood, because the presence of the big distended veins does not indicate his myocardium is damaged and unable to pump it. The reason he cannot pump the blood around is because the heart is squeezed by the blood that is in the pericardial space. And so it would actually help to give the patient a little fluid or blood. Although that, let me emphasize, is not the essential part of the treatment. A question that simply was answered with a line that said, give him blood or blood products, that would not be the correct answer. The correct answer has to include empty the pericardial sac. but you could also give him fluids at the same time. Let's move to vignette number 16. During a domestic dispute, a young woman is stabbed in the chest with a 6-inch long butcher knife. On arrival at the ER, she is found to have an entry wound just to the left of the sternal border at the 4th intercostal space. Her blood pressure is 80/50, her pulse rate is 110, and she's cold, pale, and perspiring heavily. She has big distended neck and facial veins, but she's breathing normally and has bilateral breath sounds. Well, you again have the diagnosis. This is pericardial tamponade. In this case, though, this is the only lesion the lady has, that single stab wound. She is in trouble, she is in shock, but not with as bad parameters as the previous vignette had. And a lot of individuals faced with this patient would not bother to do two things in sequence. First, empty the pericardial sac, and then take her to an operating room to do a medium sternotomy and repair the stab wound to the heart, which is giving rise to the pericardial tamponade. A lot of people would just move right on to the operating room because as you do a medium sternotomy, that opens the pericardial sac. That will evacuate the blood that is constricting the heart, and then we can proceed with the repair of the injury. I'm pointing this out because if you're thinking on a question that describes pericardial tamponade, if you're thinking, I need to empty the pericardial sac, which is the correct thought I want you to have, if you limit your thinking to a pericardiocentesis, a pericardial tube, or a pericardial window, you might be frustrated because neither of those appears there. But you realize that the circumstances are right, and one of the options offered is a medium sternotomy. That will do it. Let's move now to vignette number 17. A 22-year-old gang member arrives in the ER with multiple gunshot wounds to the chest and abdomen. He has labored breathing and is cyanotic, diaphoretic, cold, and shivering. His blood pressure is 60/40, his pulse rate is 150, barely perceptible. He is in respiratory distress and has big distended veins in his neck and forehead. His trachea is deviated to the left, and the right side of his chest is hyperresonant to percussion with no breath sounds. With all the review that we've done and with the decision tree we already went through, you have absolutely no question of the diagnosis here. This man has a tension pneumothorax. And in fact, this is another example where the clinical findings are obviously evident, and you do not need a chest x-ray. You do not need blood gases. You don't need anything else. You are ready to save the life of this patient, which you can do by putting a big bore needle right into the second intercostal space, hopefully on the side that has no breath sounds and is tympanitic to percussion. Let the air rush out, and then put a chest tube. Now, vignette number 18 is included here for a good reason. Let me read it. A 22-year-old man is involved in a high-speed, head-on automobile collision. He arrives in the ER in coma with fixed dilated pupils. He has multiple obvious fractures in both upper extremities and in the right lower leg. His blood pressure is 70/50 with a barely perceptible pulse rate of 140. And then the question, which obviously describes a patient that is in shock, who happens to be a trauma patient, who also has sustained head injury because he is in coma with fixed dilated pupils. The question then will offer you the following. It will ask, why is he in shock? And then it will offer you as options. He has an acute epidural hematoma. He has an acute subdural hematoma. He has an acute subarachnoid bleed. He has acute intracerebral bleeding, none of which are the correct answer. The reason I put this vignette in here is to remind you that there isn't enough room inside the head to accumulate the amount of internal bleeding that is needed to go into shock. Let's review these numbers here for a second. An average size adult has about 5 liters of blood, roughly 7% of body weight. You need to lose 25 to 30% of that acutely to go into shock. In the average size adult, about 1.5 liters of blood. Well, there isn't enough room inside the head for 1.5 liters of blood and a functioning brain. So people can die from intracranial bleeding, but not because of the amount of blood they have lost, but because of the damage that was done to their brain. And so the answer here is he's bleeding someplace else. He has a head injury, but that's not the reason for him to be in shock. And we're going to repeat this because it's an important topic. Well, now we're going to take a brief detour. We're finished with a review of the shock in trauma patients, but this is a good time to remind ourselves of shock in the non-trauma setting. Let me read a few vignettes. 72-year-old man who lives alone calls 911 saying that he has severe chest pain. He cannot give a coherent history when picked up by the EMTs. And on arrival at the ER, he's cold and diaphoretic, and his blood pressure is 80/65. He has an irregular, feeble pulse at a rate of 130. His neck and forehead veins are distended, and he's short of breath. In a different setting, in the setting of a trauma patient, we have learned that big distended veins means either pericardial tamponade or tension pneumothorax, and that if he's got trouble breathing, it is tension pneumo, but this is not a trauma patient. In this setting, big distended veins simply indicate that this man has cardiogenic shock, as opposed to hypovolemic shock or vasomotor shock. He probably, in fact, had a big myocardial infarction. That's what the vignette looks like. And he needs an EKG, and he needs troponins to be determined, and he needs the care of a patient with an MI. Okay? The next 3 vignettes represent an example of another type of shock we can see in the non-trauma setting. A 17-year-old girl is stung many times by a swarm of bees. On arrival to the ER, she has a blood pressure of 75/20, and her pulse rate is 150. But she looks warm and flushed rather than pale and cold. Her CVP is low. Let me read the other 2, because there is a common denominator to these 3. 20 minutes after receiving a penicillin injection, a man breaks into hives and develops wheezing. On arrival at the ER, his blood pressure is 75/20, his pulse rate is 150. But he looks warm and flushed rather than pale and cold. His CVP is low. In vignette number 22, in preparation for an inguinal hernia repair, a patient has a spinal anesthetic placed. His level of sensory block is much higher than anticipated, and shortly thereafter his blood pressure becomes 75/20, but he looks warm and flushed rather than pale and cold, and his CVP is low. These 3 are examples of vasomotor shock. These 3 patients have lost the peripheral vascular resistance, which is part of the necessary setup for normal perfusion. And this can happen either with anaphylactic shock, the first 2 examples, or with an interruption of a spinal cord pretty high, the third example. And the key for you that gave you the diagnosis is that even though these patients have the hemodynamic parameters of shock, they do not look cold and pale and covered with sweat and shivering. They look the opposite, warm and flushed. Because the cold and the pale of the previous vignettes is due to the vasoconstriction with which we respond to shock. And in this case, it's the opposite, it's vasodilation that has in fact produced the shock. And what these patients need is primarily pharmacological treatment. They need their peripheral resistance to be restored. Alpha drugs primarily. Let me repeat this. We're going to cut away from my face now to words on a screen. Shock not associated with trauma. Okay, so shock in the non-trauma setting. If the patient is pale, cold, clammy, with a low CVP in that setting, it is internal bleeding. But if the patient is pale, cold, clammy, and with a high CVP in that setting, it is intrinsic cardiogenic shock. But on the other hand, if he's warm and flushed with a low CVP, then it is vasomotor shock.